جميعا. أنا اسمي رقية الطاسان. I'm a clinical geneticist from King Faisal Specialist Hospital. I was asked today to give you a presentation about inborn error of metabolism. We'll just move. Yeah. So this is the agenda that I was asked to give you. So we're gonna define the inborn error of metabolism. We will list the common disorders that we have in Saudi, and then we will list the common features of inborn error of metabolism. I will describe the approach to diagnosis, clinical finding, by clinical finding and lab investigation. We'll describe the approach to the management of inborn error of metabolism. We'll get some highlights about the newborn screen and also the premarital screening. I love to have this lecture as interactive as much as you can. So please, I will leave it as a discussion. So tell me, what is metabolism? Anyone can give me, what is the definition? Yes, تفضلي.
It's when the body breaks down complex molecules to smaller ones.
And where we got these complex molecules? Diet, excellent. What are the main sources of diets? Carbs, fats, or protein. طيب. Do you know metabolic pathways that it's handling these fats and like diet sources?
Yes.
Yeah. Glycolysis, Krebs cycle, glycogenolysis, glycogenesis. Yes. وش TCA؟ نعرف إنها TCA بس إيش معناها؟
It makes the NADH.
But what is it's an abbreviation for what?
Tricarboxylic acid.
Tricyclic acid cycle. طيب غيره؟ Pentose. Okay. غيره؟ urea cycle. Excellent. The beta oxidation. فين بتصير البيتا oxidation؟ فين البارت الثاني؟ Yeah.
هو الستريت لما يروح للميتوكوندريا صعب يروح للميتوكوندريا يتحول
You're right بس فين exactly؟
The border of the mitochondrial wall.
endometrius.
No. Part of the beta oxidation happen in peroxisomes.
This is from a large, very large.
Yeah. And part of it, most of it in the mitochondria. طيب. So basically these are the examples of the metabolic pathways. We mentioned about the metabolism. So as you said whatever source of energy that you are having from outside, it's get into the body in order to produce energy. All of this metabolic pathway happen in the cell. So many organelles are involved in this. Your peroxisomes, plasma membrane, your mitochondria, lysosomes, endoplasmic reticulum, and Golgi apparatus. This is the metabolic pathways that we have so far. This one was concluded in 2012. You can have it online as an interactive map where you can zoom in. But what is the thing that it's very obvious in this? لا من الشكل يعني.
Complex.
تشبه السبواي. اشمعنى هالكلام؟
Everything is connected.
Yeah. So sometimes if you get a shutdown in any pathway, it might affect the other pathway. So it's highly integrated. Okay? So you need the three sources. يعني if you are in ketogenic diet, you will lose one major source of diet. And it's the opposite. طيب. So you have to maintain all the three sources in order to have a perfect metabolic pathways. طيب. To summarize it, these are the major pathways that we're having because it will be hard to cover all. you see that fat, carbohydrates, and protein all get into different pathways or cycles in order to jump in all in the respiratory chain and to produce the end product that's important to survive, which is ATP. Okay? So if we're missing any of the steps, you will not have normal ATP and you will not be functioning. But what is important error of metabolism? Any ideas?
Toxic accumulation.
Genetic issues with the enzymes, for example, that will cause buildup of products and stop other products.
Okay.
Enzyme deficiency or defect enzyme or low activity of the enzyme present, but it is less active.
Excellent.
So the other toxic material accumulation.
Okay. And why we got this toxic material?
Defective one of the pathways.
So basically ليش اتسمت Inborn?
It's congenital.
Because it is genetic. Okay? So the person got born with it. Okay? It's different from the metabolic disorder that we see in adult patients, because you can see adult patients with metabolic disorders. Diabetes mellitus is a metabolic disorder, but it's not inborn. The people don't born with it except the genetic part of it. Okay? So once you get a genetic defect in a gene that it's related, or this gene is coding either enzyme or cofactor or transporter, that it has a role in a certain metabolic pathway. And usually the main things that it gets involved is the carbohydrate, fat, or protein. This will lead to into what? You mentioned it. Accumulation of toxin, ولا إيش? Product deficiency, or impaired production of energy. Okay? So these are the three major phenotypes that we see from those patients who got inborn error of metabolism. What is the incidence? Each one of them is very rare, but collectively they are common. So worldwide, the incidence was reported from 1 to 15,000, and in some countries it's 1 to 2 million live birth. But in Saudi, it's way much common. And the rate is between 1 in 1,000 to 1 in 1,500. And do you know why? Consanguineous marriage. And do you have an estimation for the rate of consanguineous marriage in Saudi? كم يعني? 70? 20? من يزيد؟ من ينقص؟ 30. Should we accept 70? It's too much. That's mean me and you are cousin. No way. It's too much علينا يعني. 60. You're right. So the latest is أيوة.
What?
Yes. It's crazy. Because of what?
That's a culture.
It's a tribal. So we prefer to keep certain tribes. طيب. This map is showing the percentage or the most common metabolic disorders per region. This was done by my colleague. So she linked it to the regions. So like in the eastern part, MCAD, which is fatty acid oxidation defect, is very common there. Phenylketonuria, galactosemia, biotinidase deficiency. When you go to the middle part, which is like the central region, 6-BTS deficiency, which is one of the cofactor deficiencies that is linked to phenylketonuria, and then phenylketonuria, arginosuccinic acidemia, fructose 1,6-bisphosphate deficiency. When you go to the south, propionic acidemia and arginosuccinic aciduria are very common. When you go to the western part, homocystinuria, MMA and MSUD, and HMG-CoA lyase deficiency and GSD3. Up north, we can see a lot of patients with citrullinemia, galactosemia, and VLCAD. So, but collectively in Saudi, we see most of the patients comes with arginosuccinic aciduria, citrullinemia, propionic acidemia, and MMA, and MSUD, and classic PKU, and galactosemia. And we have the highest rate of each one of them in comparison to the whole world. Yeah, and we can easily see 1,000 patients of PKU. Where in the world, like in the major centers, referral centers in the US or in the UK, you see 5 patients. But going back to the basic of inborn error of metabolism, we highlighted that. So if you have intoxication disorder, that's mean you have accumulation of toxic compound. If you have energy production defect, that's mean your mitochondria is affected. And in storage disorders, you have issue in synthesis or catabolism of the large molecules. Going deeper to each one of them, in disorders of intoxication, usually the defect is the catabolism of the small molecules. So we have very small molecules called the amino acids that it comes from our protein. We have the organic acids and the urea cycle products. So usually the defect when you have accumulation of these metabolites proximal to the defect. So if I have this enzyme deficiency, whatever metabolites above that enzyme, it will be accumulated in a toxic level. Remember that all the amino acids exist in our body in certain acceptable level. But if it exceeds that level, it will become toxin to the body. But usually the patients comes like they manifest normally. But once they get exposed to triggers, they will have the symptoms. Why is that?
That's when you use that metabolic pathway, the metabolic toxin will build up because you've adjusted the first part of it.
Right. Yeah. So if you didn't trigger that defect, you will be fine. And this is one of the major management that we do for those patients. Try to avoid triggering this pathway, defected pathway. Okay? But moving to energy metabolism, usually it's a production of energy defect. So the main source of energy production comes from mitochondria. So disorders of mitochondria, disorder of glycogen storage disease, which is the source of glucose, fatty acid oxidation defects, mainly the beta 1, not the alpha 1, and then the disorders of gluconeogenesis. So all of these disorders have interference with the energy production. So if I don't have energy, what are the symptoms that I will have? Fatigue.
Depending on the level of exertion.
Yeah. One of the major presentations hypoglycemia. لأنه the main sources of these pathways is the sugar and fat. طيب? So once you don't have the source of sugar, you will have hypoglycemia. ليش lactic acidosis?
They will use other pathways to try to compensate.
Which is صح fatty acid pathway. طيب. And it can cause hypotonia, myopathy, and cardiomyopathy. طيب. Moving to complex disorders. So now we are talking about large molecules, lysosome, peroxisomes, glycosylation pathway. So either you have defect in the synthesis or remodeling the complex cellular structure. To make it very simple, and your cell is like a machinery, okay? كأنكم داخلين factory. So it has organelles that is involved in production, degradation, catalyzing the enzymes. Then you can get the end product which is the ATP. but في wastage out of this. في تكرموا garbage. Who's handling this garbage? Our lysosome. If the lysosome fail to handle this, it's gonna accumulate. That's why in those disorders we don't see intoxication symptoms. ما بيجونا في lethargy ولا hypoglycemia ولا severe intoxication. لا, بيجوا very slowly progressive. It's similar to the house garbage. It will not affect you in the first day if you miss it. It will be accumulatively affecting the house if you didn't remove it. So this is what happens in complex molecules. طيب. Unfortunately, the accumulation will happen in major organs, which are liver, brain, fem, spleen, أيوة, skeleton, والله لا, kidney لا, no. Bones وإيش? Connective tissue, okay? Eyes, okay? طيب. So, as mentioned here, it's present with progressive, permanent symptoms like dysmorphism, organomegaly, and neurodegeneration, independent of food intake. Because waste is regardless. It's out of the 3 metabolites that we're having. يعني the breakdown of the fat, sugar, carbs. It doesn't matter. طيب. I will highlight in some examples because we cannot cover all the metabolic disorders. We have more than 1,500 disorders, so I will highlight example for each. We have defects in the branched chain amino acids. Does anyone knows what is the disorder that is linked to this? وش اسمه؟ MCAD. Maple syrup urine disease. ليش glycogen storage disease؟ طب ليش MCAD؟ كل واحد يعطيني justification. أها، وش معنى MCAD أصلاً؟ medium chain. أيوة أيوة. أسايل إيش؟ أيوة. فينها موجودة؟ ايه يعني وش هي؟ انتوا تقرون صح؟ لا انا ابغاكم تقرون. انا ليش حطتها؟ ما هو امتحان. ايش معنى اليوسين، ايزوليوسين، فالين؟ ايوه. والامكاد وينها فيه؟ فات. واللي قال جلايكوجين ما نسأله خلاص. طيب فايش معنى اليوسين، ايزوليوسين، فالين؟ It is branched chain amino acids basically. فالديفكت فين حيكون؟ if we block this حيكون فين؟ في البرانش chain keto acid dehydrogenase اللي بيعطينا ايش؟ maple syrup urine disease. ليش نسميه maple syrup urine disease؟ صح. the smell of ايش؟ the body odor is similar to maple syrup. Okay, moms say that this is very sweet like a maple. طيب. So we mentioned the enzyme deficiency. It's the branched chain alpha keto acid dehydrogenase. The elevation of leucine, isoleucine, or valine. طيب. What's the symptoms that they come with? ومتى يجوا؟ Okay. في يوم؟ ايوه. in which age؟
3 years old.
يا ليت لا، اتمنى 3 years. لا، اول ما نعطيهم الفورمولا. very very early. طيب ايش يجوا فيه؟ vomiting صح، feeding intolerance، vomiting، غيره.
Sweet smell.
صح. yeah. إيش؟
bloated. They don't digest.
They don't digest. Why?
The enzyme that like break down these
إيه.
amino acids are missing.
لا they digest it. هي مش كذا. هي they don't degrade these amino acids. That's it. طيب غيره. This patch is quite. What do you think?
Crying.
إيش؟
Crying.
Irritability نسميها. Okay? Yeah, you're right. Crying. Yeah, they are irritable.
Seizures.
They come with seizure, and this is really bad. Once they come with seizure, we're done. They come with encephalopathy. ليش؟ لأنه these toxic metabolites directly goes to the brain. So it's very bad disease where you have the risk to have cerebral edema, encephalopathy, and sometimes death if you couldn't catch them. So how we treat them? أول ما يجوا أيوة we stop. وش stop؟ stop كل شيء؟
Only the food that has these.
أيوة في سبيشال فورمولا إيش فيها؟ بيكون فيها كل الأمينو أسيدز إلا أي which one is the most toxic one؟ leucine. We call the crisis acute leucinosis. طيب if we restrict the three إيش الwithdraw علينا؟ still أنتوا عندكم baby you need him to grow. Do we need to supply them with anything?
It depends if they are essential or not essential.
Are they?
They're essential.
They are essential.
Ones that are similar in their structure but not exactly them. So like maybe you add methyl or something to the structure to make them avoid the.
No, you cut all the three sources and then you measure all the three and you have to replace two of them which are not that toxic, valine and isoleucine, لأنه حيكون عندهم secondary deficiency. Okay, so you need to supply the two, but with the strict guidance from the dietitian. تفضلي.
Do you have enzyme replacement?
No, we wish. No, we don't.
Do they do for them liver transplant?
Yes, excellent. So this is the treatment, and it's nice and curative. But if you catch them early, unfortunately we don't catch them that early. Okay, so we have two options. أكمل? We have two options. Yeah, you restrict food and you give the supplements for life, ولا you do liver transplant. إيش الwithdrawal على liver transplant?
Immunosuppressed patient.
You give another disease.
They're small.
You have a patient with immune deficiency. تفضل.
Isn't it part of the newborn screening?
It is. It is. It is. It is.
It's not,
Yeah. So nowadays we catch them earlier, but not like before we cannot. Like they come with us with very late presentation.
20 years or
Even if you catch them early, there are restrictions in the liver transplant.
Yeah, because they're small.
Where's the donor? Because if you're gonna go in the waiting list, it will take years, huh? If you're gonna go through the family, most of the relatives will be carrier, so you have 50% enzyme deficiency. We catch it. في case reports إنه yeah, we did it for like neonates who are like 40 days old. We can do it. It's doable, but it's not easy. Okay, so even though if they start with the restriction and they're highly strict kids, they can come. It's إيش صار؟
أحيانا هيك بيعمل الروح بيرجع.
طيب اوكي انا عندي طلع
ايه عادي هلا ثواني بيرجع.
okay. So even if you restrict, you can't avoid the triggers from outside. Every person will have the risk to get exposed to stress, any infection, stresses, like you cannot control it, but the risk is still there. طيب. But once you see them, it's an emergency case that you need to handle.
Doctor,
So
so sorry.
we're gonna highlight about this in another slide. But moving to another category, which is the fatty acid oxidation defect, which under the energy production defect, I will highlight the most common one. MCAD is one of these disorders, but no, it's not really that common in Saudi in comparison to this disease. Because I was asked to tell you about the Saudi experience. So VLCAD, it's a deficiency of the very long chain coenzyme dehydrogenase. So this enzyme is important to catalyze the initial step of mitochondrial beta oxidation of long chain fatty acid. The issue with VLCAD that it has 3 different presentations. And unfortunately, you can see these different presentations, variability, in one single family. So you have a neonate who comes with severe hypoglycemia, lethargy, hepatomegaly, early in the neonatal period. Or you have the hepatic form where you have a normal kid, but when he starts to reach the age of 3 or 4, he starts to have episodic hypoglycemias. That is triggered by stress. Or you get an adult man who's perfectly doing well, but when he started to get into the gym and he do exercise, he gets rhabdomyolysis crisis. And it can happen in one family. What is the explanation? Nobody knows. We used to have a test that's specific for the enzyme level, but it's very invasive. We do it in the liver, like from the liver tissue. But now with the genetic testing, we don't do that anymore. But some related to the level of the enzyme, okay? It's included in the newborn screen, so it has a specific marker. It's called C14, which is the acyl carnitine. So it's in the long chain fatty acid. You manage them by avoiding fasting. You give low-fat diet that it has the long chain fatty acid, and you replace with MCT oil, which is the medium chain triglyceride. This will overcome the defected pathway. بس MCT oil is contraindicated في MCAD. Excellent. طيب, moving to the complex disorders أو اللي هي large molecules. يعني the common one is lysosomal storage disorders. في peroxisomal, في glycosylation defect, but I will highlight on this one because it's more common. So the defect usually in the breakdown of the long chain of sugar molecules, we call it glycosaminoglycans or mucopolysaccharides, from which the name is taken. So those patients will come with coarse facial features, skeletal anomalies, short stature. They have restriction in the joint movement. Some of them they will have cognitive involvement, and some will have heart involvement, mainly in the valves, and hepatosplenomegaly. Many types, MPS 1 through MPS 6. It's all included in the newborn screen in Saudi, but it's some of the types it's included in the newborn screen because there is a therapy for them. In certain states in US, and it's not even in the whole world. So the old way of diagnosing them, we simply do urine gags, which is the glycosaminoglycan, and in each type you can see markers. طيب, so dermatan and heparan can be elevated in MPS 1. طيب, it can be elevated in MPS 2. Heparan only can be elevated in Sanfilippo. Okay? But what is the problem with this test? It's not specific. It doesn't tell you what is the exact defect or what is the subtype. That's why we need to do the enzyme assay. And it can be done in the blood. And nowadays we do only genetic testing. It's easier. For some of the types, we have enzyme replacement therapy, and we can do stem cell transplant if we catch them early. Usually in the first 2 years of life. If we pass this, خلاص يعني it's not helpful, honestly.
Doctor, do you know, I know it's probably not an effect yet, but do you know if there are any diseases that are being researched right now to be treated by gene editing?
Yes,
Yeah?
some of these subtypes.
Okay.
What is the issue with that? You have to catch them very early. يعني their window, and it's clinical trial, not yet approved. So the window is the first 2 months of life. I mean, come on, nobody can get it unless you know the diagnosis antenatally. Okay? And who gonna give the risk for that? طيب, any other questions?
Do we need to know the markers for each disease?
So, إيش؟
Do we need to know the marker for each disease in this?
No. You just need to know that you do the urine gags. It's just for you to know that this is really non-specific, and we don't do it honestly. Yeah, it's all days. But moving to the clinical approach, so history and examination in every patient is the same, but there are certain highlights in the history that you need to pay attention to in order to direct your approach to metabolic disorders. But we'll leave it for discussion, guys. When you're gonna think about metabolic disorders?
And not proportional reactions to triggers. So for example, if they just are eating normally, but a normal formula, and then they have a severe reaction. Or if they have a small infection, and then they have a really big reaction. For example, their body reacts.
What is the other word? Can you repeat it?
Yeah,
I lost you in the middle.
Abnormal reaction to a minor trigger, or like something that's not supposed to elicit a problem.
Something not usual.
Yeah.
Mm-hmm.
So no, not usual, but then their reaction to it is severe.
Okay. But this is mimicking, like nowadays, these neonates, like they are allergic to anything. Like now they are getting to the goat milk, which is getting trendy. لأنه cow's milk allergy is very common in the neonates, صح? But you're right. So if they got the symptoms, but like after having regular formula or certain exposure to certain sugar, like fructose. Some of the disorders, like they are fine until the age of 6 months. Once their mom introduced fructose, which is fructose intolerance, or fructose 1,6-bisphosphatase deficiency, they start to have the symptoms. Some of the patients, they got exposed to protein, as you said. But nowadays, why I'm saying that it's getting common, because we're seeing this cow's milk allergy. But what will be the response? يعني for cow's milk allergy بيكون عندك vomiting, diarrhea.
So not proportional response.
Yes, so what is it? What they gonna come with?
Severe hypoglycemia.
Yes.
Like comatose, lethargy.
Lethargic. So you don't see them behaving well. Like, normal kids will react يعني in a regular way to any allergy. Yeah, other.
Their milestone of development, either mentally or their body growth, will be different than
Right. So they have developmental delay and they have growth failure.
and
Intellectual disability, yes.
seizures, neurological disorders.
Right. Usually the seizure become interactable seizure. So you don't with regular anti-epileptic medication, they don't get respond. So you need to think about metabolic disorders. طيب, what else? Someone mentioned about family.
Family history.
What is in family history?
Previous
تونا حكينا فيها consanguinity. أول شيء تسألوا عنه consanguinity. Family history of similar condition. Family history of neonatal deaths or infancy deaths. Okay? Very bizarre presentation. Family history of liver transplantation. You will get surprised. You will see a lot of positive family history. طيب? And usually you got the key from the family history. What else? We mentioned about childhood and adulthood. Normal kid, but he got lethargic easily. He has diurnal variation. Once he got into the afternoon time, he's hypoglycemic and lethargic. We think about energy production defect. خلاص. When he plays, طيب, change in the urine color. We think about energy production or rhabdomyolysis. Body odor. You need to ask the family about the body odor. طيب. In physical examination, we mention about failure to thrive. So the growth failure. The dysmorphism, excellent jaundice. Dysmorphism mainly in the molecules effect. Hypotonia, abnormal movements, seizures, altered mental status. Eye exam is very important in metabolic disorders. طيب. We can see very pathognomic finding in the eye exam, like cherry red spot, which is in one of the rare lysosomal storage disorder called Tay-Sachs disease. Cataract in galactosemia. الميوكوبوليساكرايدوز شو يكون عندهم؟ mucopolysaccharidosis اللي قبل شوية حكينا عنه دول. They have accumulation in the eye. What it's called? Huh? I'm sure that you know mucopolysaccharidosis, صح? Because I know that the guys, they know about it, so I'm sure that you get exposed to it. ها كلهم عندهم corneal cloudness إلا واحد. The Hunter one. MPS 2. الcloudness هذا إيش؟ The gags is accumulated in the cornea. طيب? Except for the Hunter one. That's why they called him Hunter. Because he can see. Right?
Is it the ISIL disease or something?
لا ISIL is different. No. طيب. بما أننا ذكرناها. What is the mode of inheritance of these disorders? Autosomal recessive. كلهم? Hunter is آخر كلام؟
Yes.
ليش الأولاد أحسن منكم؟
لا.
X-linked صح. طيب is girls can get the risk to have it? Carriers. صح إيه أكيد carrier أيوة.
So are there some diseases where if they, it's a spectrum, so if you only have one link of the gene.
هو قبل ما لحظة أرجع لك carrier المامز معناها إنه it's an X-linked recessive. خلاص؟
Yeah.
طيب.
Is there?
It's an X-linked recessive. لا هذا اللي أعرفه ما أتذكر إنه dominant. Okay. بس back to your question.
Yeah. So sometimes in some diseases, if you have one copy of the gene, you can have manifestations of the disease but less severe. But if you have two copies, then it's more severe.
But this is not applicable to
Okay,
Hunter.
this one. Okay.
هو it's an X-linked recessive. But our ladies or females are at risk to have it.
In one case,
يلا قوليها.
when the disease X
أيوة.
is blocked or
What we call it?
it's knocked out. The disease one is expressed and the normal one is like blocked.
So usually إحنا عندنا two X's.
Yes.
I have this one that it's defected. Or I have the wild type or normal. خلاص? When I will have the manifestation?
If the normal is not expressed and the abnormal is not expressed.
نسميها X inactivation. خلاص? So usually God protect females by inactivating one of them لأنه you cannot overexpress your X's too much to be expressed. But it could express the diseased one. But will be like the boy. She will be Hunter.
She will be Hunter as well.
Yeah.
But even if
So if he silence your normal copy and he activated the normal one, that means you will manifest the disease. The theory behind this, it's called skewing mechanism. So that single gene, it will skew the activation. Okay?
Like, I have a question. Does this happen earlier on in the embryo development, or does it happen later? Because sometimes we learned about this is that some parts of your cells in your body have one X activated and the other X inactivated. So it depends on like.
I don't remember in which stage in the
Okay.
embryo, but it's, yeah, of course, in the embryo
All
stage.
women, okay, so all women that have that are carriers also.
It
have
applies to all X-linked disorders.
Okay.
طيب, the recessive one, it's major because if it's recessive, you're gonna have it. But there are X-linked dominant ones, so the mom can be only carrier, and she will have it on her offsprings
Is there a possibility that it's X?
or her male offsprings.
Yeah. Is it possible that she's X dominant, that she has the X that is defective be the one that is expressed?
Could be.
So
I
she
mean,
has a
the
50-50.
mechanism applies to all, you know. I mean, it's one mechanism. Now there is a test that we can do it. I mean, it's really beyond this discussion, but there is a specific test that you can test the inactivation. طيب. So we mentioned about the clinical finding. Is there anything else that you want to add to this? So you know how to approach to a patient that you suspect metabolic disease? طيب. Now moving to the investigation. There are essential basic labs you need to do once you are in the emergency, ولا you are in the pediatric department, ولا you are going to the NICU. You need to do blood glucose to any baby who's presenting with the presentation that I give you. You need to do ammonia. You need to do blood gas, lactate, and urine ketones. Those are the 5 major basic labs that you need to do. Then you can manage all. Hypoglycemia is manageable. Hyperammonemia can be manageable if you catch it early. Acidosis and alkalosis, you can manage it, okay? Hyperlactatemia, it's mainly because of the dehydration and catabolism. It can be reversed by good anabolism, okay? But the second line of testing, now you can think about extra labs that it can give you hint to metabolic disorders like CK. And CK is an indicator for what
Kidney and muscles.
اللي هي what's 3 categories that we describe. Intoxication ولا energy metabolism ولا lysosomal. It's an energy metabolism. Liver profile. اي كل الثلاثة ليه؟
It's responsible for. It has all the content.
لأنه your machinery for all enzymes في الليفر المسكينة. ف you need to make sure that the liver enzymes are normal ولا لا. Coagulation profile.
Hemophilias.
لا أنا ماني blood ماني hematologist.
You can test for certain enzymes in the blood. You mentioned that.
Coagulation profile, it's reflecting what organ?
Liver.
It's your liver function, ها? liver عندها 3 أشياء. It's produce the sugar أو metabolize the sugar. It's control the coagulation and it's control the bilirubin. فإذا عندك jaundice ولا coagulopathy ولا hypoglycemia, your liver is gone. Okay? It's one of the indicators. It's also an indicator for another specific metabolic disorder. حد يعرف إيش؟ يعني أول ما بيكون عندي coagulopathy خلاص I think about it and it's in the neonatal period. And it's a pure liver disease. هلا؟ No.
Someone said it.
يلا قولي.
G6PD.
لا G6PD, it's a very nice cute disease. Don't eat beans. That's it. No, it's more serious. It's tyrosinemia. So tyrosinemia, it's a defect in the enzyme that is degrading the tyrosine. Tyrosine مش هو اللي toxic. There is another metabolite involved in that cycle called succinyl acetyl, and it hits the liver. And usually the patient comes with severe coagulopathy. يعني we see INR of 6, 8, 9 in the neonates. طيب we do renal profile لأنه kidney is important to detoxify our metabolites. You do CBC لأنه sepsis can be a trigger for these disorders, and uric acid for glycogen storage disorder that it can cause hyperuricemia. Our second tier, you do it in consultation with a metabolic physician. So those are very specific. You do the acyl carnitine to check the fatty acid oxidation defect, some of the organic acidemias, some of the amino acidopathies. Plasma amino acids, it gives you quantitative results for the amino acids, each amino acid, all the amino acids that we have in the body. And also you measure the organic acids, and we can do enzyme assay for certain disorders. طيب. So for oh my goodness احنا ما بقى اللينك كم احنا بدينا متأخر. طيب quickly management, you follow the approach of suspending, supporting and scavenger. Suspend, stop any source. Stop every source that you think of that it will be toxin. Protein, fat, stop it. And then you replace it by simple sugar, okay? Minimum we give dextrose 10. Sometimes we add IV lipids if it's not contraindicated, and sometimes we give insulin. ليش نعطي انسولين في واحد lethargic وخايفين عليه من hypoglycemia؟
Because you're administering dextrose, so you want the cells to benefit.
لأنه if you give dextrose you might have the risk of hyperglycemia. فلما لما يكلمونك مثلا nurses يقولوا لك إنه عنده high glucose، هتقولي وقفوا الدكستروز؟ No. We'll add insulin, but it will have a benefit. لا هو المريض بيجيكم ايش؟ بيكون عنده ايش؟ D2. He's in very catabolic stage. فyou will enhance anabolism. So the insulin is the solution to enhance anabolism. As much as you can, you need to enhance anabolism. طيب. Scavengers, usually we give it to the hyperammonemia patients. There are certain scavengers called sodium benzoate or sodium phenyl acetate. It's an IV medication. It should be highly monitored. It can cause electrolyte imbalance like potassium imbalance. And sometimes if you don't have these things, because these things are only restricted to tertiary hospitals, you need to dialyze the patient, okay? Sometimes we give some cofactors if we are suspecting cofactors deficiency. Moving to the newborn screening program, so it was established only at King Faisal Specialist Hospital in 2005. So it was only restricted to King Faisal. And then 2 years after, it got expanded to tertiary hospitals from MOH. But this year, it's generalized over all governmental hospitals. Not yet covered by private ones. So it's still optional, which is so sad. But the government is working on implementing it as mandatory and to be covered by the insurance companies. It's very simple. It's a small filter paper. You get blood from the health stick. It's even very minimally invasive. And then you put it in this machine. It's called chromatogram. And then this is what you see. So this is a sample of PKU. You see the ions of each metabolite, and if it's peaking, this is the level in comparison to the normal one. So it's alarm you. طيب. And then we got this report. So this is the initial newborn screen report. Usually they just flag it as abnormal, and they put what is the abnormality that they see, and they have a reference level, okay? Once we get this results, we don't call the patients and start the therapy. We call them for a recall sample, okay? Do you know when we do the test? The initial test. ايه أي ساعة في العمر؟ At 3 hours. Okay. Another guess.
7.
ها؟
6 or 7.
6 or 7. اللي هنا حسسوني انكم معانا. 48 hours. Who said 40 hours? Yeah. Why?
Because once the baby is born, still there is function of the maternal enzymes. So we need them to wane off, then we can do the test.
Okay.
I think not the maternal enzyme, but the nutrition.
أيوة.
I come ready from the mother side, from the blood. So it is not like he needs to process it.
No.
She's saying
Once you are off your mom's tummy, you're done. خلاص ما بيبقى منك بالنهار إلا الإميونوجلوبولينز.
so they don't.
وش يصير؟ ليش هذول الكيدز مش قلنا إحنا they born normal. حتى they are very pretty kids. Once they get exposed to trigger, once ما إحنا we feed them, they start to have the symptoms. فهو المفروض إنه he's already relying on whatever he received from his mom, but he needs time to metabolize the formula that he got after birth. فتحتاج at least 24 hours to 48 hours. The ideal is 48 hours. If they are very sick, we need to do it earlier طبعا. We cannot wait for them. خلاص؟ ليش؟ لأنه أنت you want to get it reflected in the test. فما بتطلع لك في clear levels unless you have 48 hours. طيب, do you know how many disorders we cover في newborn screens السعودية؟ Guesses. 6.
How much it costs?
200.
لا how many disorders?
Oh, it's
Yeah.
1,500.
كم عدد الديسوردرز for like
And not 6 more.
عددها في العالم كم؟ How many metabolic disorders?
1,500.
Yes. احنا بنغطي بس كم منهم؟
200.
يا ليت.
All of them.
100.
No.
50.
50?
1,400.
لا. يلا guys.
20. All
20.
Oh, cover in the test. I thought you meant in Saudi.
No. It's yeah.
because it's expensive this time.
لا. لا. مو عشان كذا. هي عشان إيش الفائدة إنك you screen for something?
You catch it earlier on. It's treatable. You want to
If it's treatable ولا لا؟ يعني ال 1500 هذول not all of them are treatable. You have to live with them يعني. But there are things that you can intervene earlier so you can stop the complication. But this is what they ended up. وفي شغلة ثانية, what is the cost effectiveness? يعني إذا Tay-Sach is not common in Saudi, why I need to test it? فهذول, all of these were listed فين? In the map that I show you. Most of them يعني, ما أقدر أقول لكم all, but most of them are listed in the map. But this is based on the research that we have in our region. If you go to different country, it's completely different. In certain countries, it's only 4 disorders. In certain countries, it's 36. But it's tailored based on the need of the country. Usually, these tests done in highly developed countries. يعني, unfortunately, some of the underdeveloped countries, they don't even have any newborn screening. But it's important to know that you have 18 only disorders that is related to inborn error of metabolism, but the first 2 are endocrine disorders. But why they added them? No, they are treatable. We need to catch them early. Okay? I think we mentioned that. Moving to this one, I don't know why they added to your agenda. But you know that the premarital testing does not cover any of these.
It's cover only the sickle cell and leukemia.
Yes, and
hepatitis B, C, and
infectious. بس إيش المأخذ على المكتوب هنا? I got this from the website of the MOH. and please carefully read it and tell me what you think. هذه آخر سلايد عندي.
Family planning.
إيش يعني؟
I mean, if they know the chances.
This is crazy. So they are saying that it will provide the partners and spouse with an option that help them to plan for a healthy family. And this is what we get in the clinic.
They need
We get a young couple who has an affected kid with these disorders, one of these disorders,
they want
and they are blaming us why wasn't included. Why you told us that we're sharing this gene? Okay? So this is the bad thing about it. So this is over-promising for something is not existing. Yeah, sad. But what we do here, in order to overcome this, especially in our clinic, we know the families by tribes. So once we catch a family, we advise them to spread the knowledge to their relatives. And we open our clinic for extended premarital testing for the patients who are or families at high risk. We got a lot of requests. And now it's very clear in certain tribes, they know that they have this risk for that disorder. They come with this idea and they want to test their future partners. Okay? So we're trying our best, and this is very primitive. It's need a national program, but we don't have it. But we can offer the testing for anyone who's over 18 years and who's interested to know if they have a carriership for these disorders.
Do they have to pay for it? Do they pay for that, or do
Our patients, no.
Nice.
It's covered.
Do we have people that come before they get married? So they want to get married, they're about to get married, but first they want to do genetic testing?
Yeah. So like if I have a family who has an affected child who's like 5 years old, and his older brother is like more than 18, and he wants to get married to his cousin, we accept them both and we test them. We see if they are sharing this or not. Even though if they want to continue the marriage, we can offer BGD. Okay? So pre-implementation testing. So we can select the normal fertilized ovum. And we have a prevention program. So even if you get an affected child, because the risk of these disorders is 25%. For each pregnancy, they will have the same risk. But we can offer prenatal testing for these disorders. And most of these disorders are covered by fatwa that it can be abortable. طيب. I think I'm done. Do you have any questions? So we cross the Inborn error of metabolism as a definition, inshallah, not very clear. You got the common disorders in Saudi. We highlighted the main common features of metabolic disorders. We got the approaches in terms of clinical finding and investigation. And also we highlighted the management. We highlighted on the premarital screening and the limitation that we have so far. And also we covered the newborn screening. I'm done. Thank you so much. في أحد عنده